The following podcast was recorded at the ANZICS Safety and Quality Conference 2014, Rapid Response Teams. Owen Roodenburg discusses education and supporting of JMOs, using the basic course and the medical lead.
My name's Owen, I'm one of the intensivists at the Alfred, and I'm actually really delighted to be able to speak to you about something that I'm very passionate about, that I think a lot about, but more importantly as a sort of a doer, I do a lot about it. I supervise a lot of training and that sort of works at multiple levels, particularly through the medical training and critical care training at the Alfred Hospital. That's really where I'm coming to talk to you about today. We've heard a lot about education and training, from educating the MET teams and educating nurses, and there's been some great and I think quite aligned sort of points made about that education. And I've been specifically asked to talk to you about educating and supporting the junior medical staff in the context of those staff who are otherwise responsible for those patients for whom a MET call or a rapid response team is dispatched to. So they're the ward doctors, if you like, and the junior doctors. But I want to start by also bringing this back to the patient. All of us really are in this for the same reason, and that is that we're looking at how we can make the outcomes in whatever way that we sort of think outcomes are important actually relate to the patient. And if you look at this, I don't want to go through any of the debates about whether rapid response teams are good or bad. I think they're here to stay. My approach to that is that, look, this is the job that I've been given. I'm going to get on with it and do it properly. Except to say that if you take on board a task that you don't believe is going to be useful, it's unlikely that you'll deliver a successful outcome. In other words, you'll prove that task is not going to be useful. Does that make sense? And I think that really forms the basis for where I'm going to go with talking about educating junior medical staff. The other thing I would say is that talking to an auditorium full of very skilled and educated nurses, I don't want this talk to really be a time where you can tune out. So if I say the word doctor and you're a nurse, you can, or even if you're a doctor, you can replace that with nurse, because I think the concepts and things that we can talk about in the next 10 minutes or so can readily be translated to other environments, but I'm talking specifically about junior doctors. Now, the nurse in this scenario, if we've already talked about the patient, is often the messenger that triggers that rapid response. They're the person who's interpreted the vital signs, made sense of the situation or not, and raised the alarm and escalated. Now, the traditional model for that was very much to say, I need a doctor. We still haven't challenged that paradigm of daily ward rounds, and so still much of our medical attention to patients is delivered in a point in time, often once a day, at which the rest of the 24 hours is delivered by continuing that plan. That plan is then modified, usually because of a trigger, and that trigger is often brought about by a nurse. Now, in that context, what do you actually want that medical response to be? Because what we're talking about is someone who is now deviated from the plan, either because the plan wasn't clear, or it was incorrect, or it's ineffective. So ideally, you want the ideal medical response for that patient in particular, over and above the ward round. The ward round may have brought you a consultant, a senior registrar, a junior registrar, or a resident, and someone to write it all down. And now, with the deviation, we're going to escalate, not to the doctor who can make the senior decisions, who can interpret the variation in the data that they're presented, but rather we're training hospitals, and so what we do is we delegate that task to the least skilled, the least able and empowered to make those decisions. And the rationale for this is that these are the people who aren't taken up with the important jobs like going to theatre or running outpatients. These are the doctors who need to learn. And so therefore, when there's these escalations, these doctors are the ones who actually are called on. But when we go back to thinking about this from the patient's perspective, is this really the service that we're wanting at that point in time? Which comes then to the idea of the question about whether rapid response teams are going to de-skill these patients. The idea that if we're questioning whether the junior doctor is the person to deal with this escalation, if we deal with that by saying what we're going to do is bring in an expert team who deal with deterioration and illness and critical illness and ICU, are we really saying that what we're going to do is exclude these doctors on the ward from the process? And if we are doing that, then I think the argument that we're de-skilling them is a reasonable one. We're giving them no access to the opportunities they have to learn. And so my proposition in the next 5 minutes or so is that we need to match those two conflicting or seemingly conflicting priorities about education and learning and about providing a service to a deteriorating or potentially deteriorating patient. Now, I don't think de-skilling is actually an active process. I don't think you do something to de-skill someone. All you do is you don't do something to de-skill someone. So I think saying that we're de-skilling doctors on the ward is a bit like saying someone else isn't doing the job and so we don't want to be the ones who aren't doing that job. Does that make sense? We're not going to de-skill somebody by providing a service unless we're removing something which is otherwise educationally valuable to them. Does that make sense? So, by improving the quality of the care to the patient, can we do that in a way that's sustainable so that realistically de-skilling, what we're talking about there is saying the future colleagues of yours and mine, the future doctors who are senior, won't be trained to look after these patients. And that's not sustainable. And as we heard from Alex this morning, that already happens. The surgeons who trained 30 years ago didn't look after patients with complexity or severity of illness on the wards that we have there now. So they didn't train in it. We're not de-skilling this workforce. We're just not skilling them. Now, Judy's already very fortunate he presented these words to you. You may have come across them. Noel Birch, who worked for the Gordon Training Institute back in the 70s, sort of really just developed this as a way to understand the way that people become skilled. And if we think about a junior doctor, the basic presentation of the doctor to the patient really is the point at which they've done a medical degree which gives them certification to be a doctor. And at that point, they're unconsciously incompetent. They think that they're a doctor. And the very first moment they see a patient, they become consciously incompetent. Doesn't take very long. And we work through this process whereby educating them or by learning as the person becoming skilled, we develop competencies. Initially, it takes some effort to realise that I didn't know what to do or how to do it, and now I'm going to become competent. Initially, conscious competence means that I have to work really hard every time I know this is a skill that I'm training to do. Ultimately, over time, one becomes unconsciously competent, and so we have driving and drinking and talking on the phone, which you can do if you've done it enough. And then ultimately, this is a cycle, so once you become unconsciously competent, you have a risk of becoming unconsciously incompetent again, because you now think that you know what to do, and if evidence changes, practice changes, the condition changes, or you think you know how to teach it, you become unconsciously incompetent again. Does that make sense? That's what this is really about. But then how do we climb that ladder? As a resident doctor, how do we climb that ladder? Well, fortunately, we've got some data on this in multiple industries repeated over time. What we understand is that the way that people take on task learning, and much of what we're talking about now is elements of that, so particularly role learning in organisations, and includes doctors, and it's consistent, is that much of what we learn is learnt by experience. So every one of those steps from unconscious incompetence through to conscious incompetence, the thing that takes us to the next level is experience. It's when you see the patient that you realise you've got no idea how to examine a patient, how to treat a patient. And then there's another 20%, which is said to be due to feedback, which is entering into that agreement, that relationship as a teacher-student, mentor-mentee, that sort of thing, which gives you permission to have that discussion about your performance with that experience. And only 10% really, which we're talking about, formal teaching. Now, with that other unproven intervention just before patients hit the ground, people hit the ground, we wouldn't start that process by saying what we're going to do is give you that 70% learning opportunity up front. We need some foundational teaching. And I think that's where we have a risk of failing badly with rapid response teams. even with the staff who are going on them. If we're not teaching them the fundamentals of what it is we're asking them to do, then they may well learn how to do it, but there's going to be a learning curve. And there needs to be some basic formal teaching. So that 10% formal teaching may take the roles, various roles, and we've heard about some of that, but the content that we deliver in that might be through the ICU teaching courses that we do, by basic life support training or ALS for some people. But also in our hospital, it's been about educating people right up the front about escalation protocols. These are our expectations. This is the environment that we're expecting you to work in. This is what's expected of you in this organisation. That's really just that formal stuff. But then also the things like looking at what it is that a junior doctor is actually going to do, so that we're getting them to address the relevant things. We talked a little bit, you heard a bit yesterday from one of my fellows about the night task management. We've got some really much better understanding about what sort of things the doctors are getting called to do, and we can specifically address some of those things to learn. And then the more senior people that we're asking to go on these MET calls, how are we teaching them? There's some formal content which we can really kickstart that process so that the other components of their learning is accelerated. And what we've developed is some stuff around the formal ICU teaching for sure, which has been historically there. But some other things which have explicitly addressed issues of communication, collaboration, negotiation, conflict management, and leadership. And we've done that in a way which has been married up with the experiences which we know that they will be and are going to be having on the ward relating to junior doctors. And mentoring's been explicitly formal in that as well, so that we've set up relationships between our own consultants and we've trained them on mentoring with senior trainees, and we've given the senior trainees some expectations and some relationships with junior trainees, so that this is a process which is going to be repeated as they train their trainees. Now, it's pretty clear that formal and informal separations of education is not it's not really a dichotomy that works. We know that there are elements of some of our teaching which is more formal, some which is less formal, some of it's informal, and some of that's dictated to by the time pressures and the constraints that we have, or by teaching opportunities as they present. So the question then comes as to why will these trainees learn? We can try and deliver them the 10%, but they may not even buy into it. But what is it that's going to motivate them? What is it that cuts to the core of why people do what they do? So in the last couple of minutes, if I can, I just want to address that in a way that might trigger you to help understand how we can support these trainees. Not just educate them, but to support them to learn. What we know is the carrot and the stick are out. The carrot and the stick respond reasonably well to short-term measurable learning, but in the long term they really don't carry any sustainable learning. So when we mandate people go online, they read a document at the end, they have some questions, and that's mandatory, that's a stick. And what that does is that can be completed, but it doesn't really, and it's measurable, so people like that. What it doesn't do is upskill the person very well. And what it doesn't do is upskill them for a long time, because they haven't depending on how it's structured and how it's delivered, they haven't necessarily bought into it and owned it. And really what we need them to do is to understand why it's important to them and to actually develop a new sense of responsibility for that piece of information. So cognitive dissonance is a useful theory that's having two psychologist parents permit me to talk about a psychological theory. Back in the 1950s that was developed and has been well understood by lay people to explain a little bit about how it is that people move from one position to another position and learning about that. And that is that if we hold one view and we're delivered some contradictory advice and we try and hold that view, we feel tension. It's dissonance. And the same is true as if we're expected to do a task which we're unable to do. We feel a tension. It's a challenge. There's dissonance. We feel that tension. Now, what people do with that tension is to resolve it. Much as certain musical chords will develop a sense of tension that people will want to resolve. In the same way, this inner tension which is developed from the cognitive dissonance that comes from knowing that I can't do what I'm meant to be doing, how we resolve it really comes about, in the theory, it comes about in three ways, but it really comes down to two ways. You can change what you do, or you can change what you expect to be able to do. And this comes down to the relationship that a junior doctor in this context has with the role that they've been given. If a junior doctor turns up to a ward and they see a patient that has a role for them, which is difficult and challenging, It develops tension because they can't do it, but they feel that they shouldn't have been put in this position. It's unfair on them. They were never taught to do it, and they're only going to get in trouble for it. The response they have may be very different to if they're actually turning up, escalating appropriately and being educated on that. And this comes back to another model which really talks about, I think if we look at this, we could easily put dissonance on the left and empathy down the bottom, or support. And this really talks about the two arguments about educating junior medical staff. If we're looking at this model and we understand that dissonance needs to be resolved, dissonance is reflected on the left. If we see a patient with a problem that we can't manage and we feel that we're meant to be managing it, we feel tension. Okay? Now that tension, if it's felt alone with no support, if the environment is a punitive one where they'll get in trouble for not completing it properly but not educated and supported to do that, then that person, in terms of their learning goals, is likely to regress. They're likely to do it badly and actually feel disengaged. They'll try and write off the authority that has said that they need to be doing that role, because that's the only way that they can actually resolve the tension. People will be less motivated to actually change the way they behave. If they don't develop the tension, which is what we're talking about if they have a rapid response team that excludes them, and they're supportive, so don't worry about it, this is one of the sick ones, we'll deal with this one, you can go and deal with the next patient, then we get stasis. We don't get growth, we don't get learning, we don't get development, and in that sense we're de-skilling our future colleagues. By the same token, if we're incredibly supportive, but we're not allowing that tension to develop, look, thanks for escalating it, you've done a really great job at that, and that's probably about all you'd be needed to do, because we can do a great job from here. And then all we do is we confirm the ignorance or the lack of competency that they have. And ultimately where we want to go with this is to allow that dissonance. We want the junior medical staff to be engaged in this process, and we want to provide them with the support, which is skilled at teaching, skilled at providing what the patient needs, but at the same time understands the learning objectives that junior medical staff members, team, nurses have, that they might actually develop some growth. And so I'm going to finish, and that is that using the cognitive dissonance model, we'd say that we need to allow the junior staff to be involved with these patients but provide the support, and that MET calls aren't really earlier ICU referrals. And if they are, then the majority of them are irrelevant, because most of these patients don't go to ICU, or hopefully don't go to ICU. What we really need to be thinking is about how we can use all of the skills that you guys have to deliver it outside of the core ICU geographic area, so that we can deliver the service and maintain the skills of our future colleagues. And that's where I'm going to finish. I think this is an opportunity.
For more podcasts from ANZICS, go to anzics.com.au.